Our mission here at John George Psychiatric Hospital is simple but powerful: caring, healing, teaching, serving all.
We handle over 99% of the psychiatric emergencies for Alameda County, which is Berkeley and Oakland, and about 1.5 million people, very large geographic area county. What we do different at John George and what we call the Alameda model is that we will take patients from all over the county and from every other emergency room immediately, as long as they're medically stable. We're seeing between 1,500 and 1,800 patients in psych emergency per month. But the fact that we're able to get 78% of those people home and safe every month shows that there's ways that you can work with these folks, and it's not that you have to default to hospitalization all the time. We're only putting 1 out of every 1,000 people into restraints, and I think we continually show that it's possible to do that and get people better in less than 24 hours.
The traditional model of inpatient psychiatric care is a rather paternalistic model. It's one that assumes that patients in that state of mental decompensation are unable to make decisions for themselves, are incapable of acting in their own best interest, and perhaps even more importantly, incapable of forming meaningful relationships.
Completely the opposite at John George. This is a very welcoming environment where when you arrive, people say, "Hello, how can we help you?" It's a very collaborative, soothing, calming environment where it's all about what can we do to help.
We put the patient at the center of all of our decisions. Are we providing the patient with a home-like atmosphere? Is the patient having to ask us for things that they normally wouldn't ask for in their own home or wherever they're living?
Some of the traditional components of inpatient psychiatric care that we challenged included whether or not patients could retain sufficient autonomy even in their most decompensated state, to be able to make their own decisions with regard to staying in touch with the world, watching television, keeping up with the news, having computer access, getting food when they wanted it, having access to visitors whatever time of day they wished. Many people were concerned that when people could eat food whenever they wanted, we might be driving their diabetes out of control or contributing to the obesity that is such a problem with our population. In fact, we suggested that when people leave the hospital, they're going to have to manage these challenges on their own. So better that they do so in the context of a relationship where people can be supported and helped to make healthy decisions.
It creates a caring, healing environment rather than a caretaker environment, so the patient can truly interact well and be at the center of all decisions around their care. The use of data here at the hospital is critical. We use it in order to focus our efforts around change and initiatives. We also use it in order to make sure that we're doing the right thing at the right time. Over the years, we've used data to improve our patient satisfaction scores from the 1st percentile to the 99th percentile nationally, to reduce our use of seclusion and restraints, to improve our employee satisfaction, and other critical initiatives to improve the overall clinical care that we provide here at our hospital.
I have tremendous respect for the staff here. I think they're very impressive. I would describe them as miracle workers.
I think the greatest strength is in the administration's ability to be able to pull together a medical staff, a Department of Social Services, a rehab team, a group of nurses who put the rehabilitation of the patient as their first priority.
And what I do see here at John George is a kind of teamwork on the units between the multiple disciplines, between doctors and nurses and social workers. It's not like it is in a lot of other facilities where the doctor is in charge and everybody else does what the doctor says. They truly get together, form treatment plans together. I see what is genuinely teamwork.
Project Beta stands for Best Practices in the Evaluation and Treatment of Agitation. It was a new way of doing evaluation and treatment of agitation in psychiatric patients that was a nationwide study. Several of our staff here were part of the multi-center study. John George was sort of ground zero for Project Beta. It was the first place where the guidelines were implemented and tested. It was all about creating a therapeutic alliance with patients, avoiding the use of coercion, finding the least restrictive level of care, and working collaboratively with patients to get a good outcome. And we've seen the different places that Project Beta guidelines have been implemented have had wonderful results in decrease in the use of restraints, decrease in coercion, and dramatic increase in patient satisfaction, reduction in assaults and injuries.
As a patient's rights advocate, I evaluate a facility from the perspective of the patients. And the patients here tell me that they feel safe, they feel respected, and that's the gold standard for me.
We're now in the top 10% of patient satisfaction in psychiatric hospitals nationwide. It's proof that if you have good people who believe in a solid philosophy, that you're going to have great outcomes.
We're doing things that I've never experienced in healthcare before. We're engaging patients and patients' rights in our community as never before. We're opening the doors of acute psychiatric treatment to those who are interested in helping us provide great care.